Can I switch it off? Yeah.
So anyway, when we are transferring things from my computer to the pen drive, I'll continue to speak so that we don't waste time.
Another presentation made until then? Till
It's
you
there.
get this?
It's there already. It's
Until
coming.
you come here, I'll make the presentation.
Oh, okay.
Because we are running short on time.
Achha.
Because now time is
I know.
going on.
Let Madhuri do her thing.
Actually, this is completely an impromptu presentation, what I'm going to present now. When Dr. Gautam Das invited me and gave me basically this task of moderating this particular session, I don't seem to be making a very successful thing out of it with all my presenters running into various problems. However, this is just a short presentation because he said that every region, like he put people for Eastern India, for South India, for Central and Western India, and he just told me that you should give a short demo. So this is just for a couple of minutes that we will just have a short say going on. From Western India, we have got really good stalwarts who have worked for pain management specialty in India. We have got multiple presidents of Indian Society for Study of Pain. We have had numerous conferences in western part of Maharashtra and in western part of India, sorry. Actually, the next upcoming ISSPCon conference is going to be in Indore in Madhya Pradesh, which is also part of our session. So this is just to give you, many people have been working. Some people I might have missed during my presentation, but there are these are the people who are working mostly as pain physicians than anesthesiologists or practicing any other thing. I could not find photograph for Dr. Sushila Shah, but she was one of the people who actually motivated me to go ahead with this. And then we have got all these stalwarts. Do we have a audio for this? Thank you very much. That was just a short presentation, and I apologize in case I have missed any names. Madam, you're done? Fantastic.
I'm done. Say thank you and get out.
I did show you.
I didn't see that.
Yeah,
Anyway,
this is
yeah. No, thank you. Huh?
Open photo to files,
Ikra call.
So,
What is
Dr.
this?
Vas, you have 15 minutes to talk.
Huh?
You have 15 minutes to talk.
I have 15 minutes to talk. What to do with this?
Which one?
Last one, CRPS. Okay. But it's only presentation. I'm not getting the 4% were permanently disabled and 28% had to change their jobs. The outcome of CRPS is uniformly bleak. And all these studies have done this at something like 9 years and 3 years and things like that. And they are fairly recent studies, 2009, 2006, etc. And I want to stress here the outcome after spinal cord stimulator. A 2015 paper, 2 months ago, this paper talks about increased pain catastrophizing associated with lower pain relief during spinal cord stimulation. So how much of an answer is spinal cord stimulator in CRPS? I leave it to you to judge. Turner et al. Have a very nice literature review where they found that statistically significant results, but clinically very modest results. The patients were not happy with spinal cord stimulator. And reversal, in this backdrop, I want to say that reversal of CRPS is routine at our center for the past 10 years in more than 150 consecutive patients. That is because I have looked at it in a very different way. Myofascial involvement is the primary. So what is the scientific basis? There is a study which has shown specifically that the muscle histology of amputated limbs, CRPS is such a terrible condition, patients opt for amputation and they show the muscle involvement with fiber atrophy, fatty degeneration, etc. So now this is the ultrasound picture. I have shown that the normal ultrasound picture of a muscle has beautiful outlines of muscles and a generally black background with streaks of white in it. That's the normal appearance of any muscle. It is called the sonographic signature of a muscle. And see the muscle bulk of the patient in the right hand. And the same patient, this is the CRPS hand. I'm sure all of you can appreciate what is the destruction of muscle. All the muscles have coalesced into one. This is the extensor. See the small size, it is only 0.18 centimeter as against the 0.61 centimeter. So after dry needling, before dry needling and after dry needling, I'm showing you the vasomotor change in this. This is a pre-DN which shows 37 to 38 degrees. During the needles, it is still about 37, and post-DN, it is 35. It's a very clear situation where there is a vasomotor change effected on dry needling. So CRPS patients come like this with very little mobility and a swollen hand like this. And I'm not playing the video here. Within 11 days after only dry needling, you can see he's lifting a bottle of 1 liter water, that is 1 kg. And all the self-help issues like eating, combing, etc. are possible in this man. This video will not play. This was a patient with severe dystonia who could go back to full ability. So in this patient, what was happening was, day 3, this is the situation, day 5, day 10, day 12, and day 17, she's able to hold the bulb of a sphygmomanometer, but she's still at 0. She cannot raise the pressure more. Whereas at day 22, you can see that she has given 4 pounds per square inch, whereas her normal hand is 8 pounds per square inch. She will need another 15 days of needling to go to the normal hand power. This is a patient, oh, I'm so sorry, this video will not play. It's a wonderful video of a lady she is literally jumping when she walks. She's a doctor's wife. CRPS was undiagnosed for 12 years. 6 days of treatment, look at her ankles, how small they are. And this is her climbing stairs and walking. Again, videos are not playing. I'm very sorry about this. Bilateral CRPS is something horrible to have. They can't even get out of bed. Everything has to be done by others. They are just sitting there. And this lady, after our treatment, 3 pounds per square inch in the right hand, 4 pounds per square inch. She was going to US to help her daughter-in-law who had delivered. So from complete disability where you need others to help you to going and helping others. That is the situation. This has been published in Pain Medicine. This is a patient who came to me with CRPS 2 actually, after radial nerve damage, after needling and other treatments. She has recovered, but you can see here, this finger, the ulnar claw is developing because of the ulnar nerve damage. And so this girl was very fashionable, and she said, I can't put my hand into my jeans pocket. So she wanted to go for surgery. I told her CRPS recurrence is very high after surgery. She said, it's okay, you will treat it, and she went. And as expected, she did get CRPS, and you can see that she has gotten CRPS, but again, after our treatment, she recovered. This kind of predictable recovery in CRPS is unheard of in CRPS literature. You can go anywhere and check it. It's impossible to see such results. So this case, whoever is interested, it's also published in Pain Medicine. So how did I start all this? When I saw first, in 2003, I also thought like an anesthetist and did a stellate ganglion block, mild relief, then continuous brachial plexus block, which was my specialty anyway. I did it. This is the continuous brachial plexus catheter. This is another patient with a pump. Then I found that in spite of keeping the catheter in situ for something like a month or 1.5 months, the stiffness of the hands and the motor disability does not go away, and it was difficult. And I was finding it very difficult to keep the catheter in these patients because of infection, falling out, etc. So then came this patient. Video will not play. Terrible. But this girl, even after 7 days after continuous brachial plexus catheter, you can see she's still in a lot of pain with abduction of the shoulder. So I said, let me try needling. I did needling in her, and immediately after needling, this is the picture. From here, she has gone here, just within half an hour time. So this video will also not play. So dry needling of muscles. I knew now, I had an answer, but why I got this answer, I had no clue. I had no idea about the scientific basis of this. So till I saw this patient where there was a severe dystonia, and I realized that when flexors contract, the extensors should relax. And vice versa, when extensors contract, the flexors should relax. And in CRPS, what happens is that both extensors and flexors contract together, called co-contraction. So once I had this understanding that their hand position is because of co-contraction, I realized that there is a scientific basis for dry needling. Dry needling relaxes the muscles, and as a result, that position will go away. Instead of co-contraction, you will get coordination. Co-contraction, how does it produce the hot, swollen hand? That is because of the difficulty in movement. There is a strain on tendons. Friction between tendons and synovial sheath in the palm and hand, tenosynovitis, rather like dequer veins, but this is a dequer veins of the whole hand, which is a terrible condition. And so this is our patients who come like this, swollen hand, and later recover. These, I don't know how much you can see. This is the normal hand. You can see that the tendons are here, and there is no effusion. But the other hand, the abnormal hand, look at the effusion around the tendons. This is unequivocal proof that the swelling is inside the tendons, inside the synovial sheaths, and there is no subcutaneous fluid here. So whatever I was thinking was right, and the same effusion has become a lot less now after 20 days, and after about 30 days, this hand resembles the normal hand. So by dry needling, we are sorting out this same situation. You can see that here there is a lot of effusion. After dry needling, this is the palmar aspect, flexor tendons, and this after needling, this is the situation. So I had proved that there is co-contraction. I have also proved that why it causes the swelling and hot hand in CRPS. This also is published. Then came this girl who proved everything to me in that look at this abnormal muscle here. This is the normal hand. The same girl, after needling, the muscle outlines start appearing, and this is becoming normal as her hand is getting movement. So this is cause and effect I am able to show on an ultrasound. You see, unfortunately, if I as a specialist say that I get these results, I'm looked at with skepticism. But if I show black and white pictures of ultrasound, I get a lot of credibility. So anyway, as a result, so this is another patient where a lump like this has started getting organized into muscles. This is of the lady who bilateral CRPS. So this I could publish in Pain Practice in 2013. So this became a starting point for me. So I realized whatever concepts I have about CRPS are so revolutionary that to the research community in the world, I cannot tell them everything. If I tell them everything, it is too much for them. I have to give them little doses of truth as I saw it. So I published, I didn't say what I do, I just said these are the ultrasonography changes in CRPS and published this. And then what we do is extensors and flexors are alternately needled, and this is why the co-contraction becomes coordination. And these are videos. So I have also seen that before and after I have shown in the second paper. This is in 50 patients. This is in press. This article is accepted. It will appear in another 3-4 months probably. So again, another patient showing those changes. These are videos. This is a patient of CRPS-2. This is an elite forces soldier who's an officer who, after CRPS-2, you can see he has recovered enough to stand and walk. I was to show this video of him walking, and here he's talking about how his pains, the causalgia pains, are very much less in him. He is a very courageous fellow. In spite of being paraplegic, he is now competing for the Para-Olympics, and he's training to shoot. He's a sharpshooter anyway. And what he found was he could not shoot and concentrate and shoot because of the severe causalgic pain. Whereas after my treatment, he is able to shoot. Only dry needling, nothing else. In him, the sympathetic ganglion block did not work, but dry needling worked. Not only that, his thigh size has increased, as you can see, from 11 or 12 to 14. And not only that, he is able to lift the foot off the ground. He's saying all this in this video, and courtesy Bill whatever his name, Bill Gates, we are not able to show this to you, the videos. So it's not only dry needling. Dry needling does not mean sticking a few needles here and there. You have to understand the kinesiology very well, that act of co-contraction, act of agonist, antagonist, etc. very well. And then, of course, your muscle anatomy has to be perfect. And physiotherapy is a very important thing after dry needling. We have to do it. And these are our patients who came completely disabled, and after that, small acts of daily life which are impossible for a CRPS patient, they are all doing: buttoning, combing, eating,
Madam,
lifting a bottle, opening a bottle, etc.
Yeah.
Okay, so I have finished my talk here. Because the videos were not playing, I have kept up to 15 minutes instead of 20 minutes. Okay, so thank you very much for a patient listening. And I would love to teach dry needling to all those who may be interested. dry needling is the philosopher's stone of pain management. You can do any number of blocks very well, but you will not get results. But if you add dry needling to your perfectly performed blocks, you will see that your patients are going first class. So interventions are about your ego, what I can do, but dry needling is about how can I get my patient better. Neither can be used in isolation, just dry needling. Dr. Jain introduced me as a person who's very fond of dry needling. That is because I have found it to be the philosopher's stone of pain management. It is not that I do only dry needling, I do all the other blocks, but in CRPS, it is the dry needling which works better than anything else. Thank you very much.
Thank you, Dr. Lakshmivas, for that excellent talk. And the concept is that we have orthopedic surgeons who deal with bone, we have neurologists who are experts of nerves, but there are no doctors for muscle. There are no muscle doctors. So she is giving a point that muscle is the primary pathology in these conditions, and there are no experts. There are osteopaths and there are some pushers, and alternative therapies are there. But in our modern medicine, there is no dealing with such muscle pathologies, and you can see, if she sees the patient, she can find out that this muscle is under contracture. And then you do the needling and then muscle becomes straight. That is the concept, that muscle is under strain, and then it normalizes, and immediately, sometimes in the same evening, the patient gets about 70 to 80% relief. So it's a very magical treatment, and those who are interested, they can discuss with her. So due to brevity of time, we will close this here, and any questions, precisely one or two questions, I will invite from the audience. Any questions?
Madam, my question is, how you select these needling points, and what are these number of these needles?
See, you have to look at which muscle is abnormal, which muscle action is abnormal, and then put as many needles as, if you have to look at which muscle is abnormal, which muscle action is abnormal, and then put as many needles as, if you want a rough guide, about 1 centimeter distance in the longitudinal axis of that muscle and 1 centimeter in the cross section of that. In my paper, which is going to be published now, there is the Dequer veins paper as well as the 50 patient paper. In both, I have shown how to put the needles, and these needles are done under ultrasound guidance. Then, so that I know that exactly I am inside which muscle I wish to be in. So it is not something like I am sticking needles here and there indiscriminately. If I want to enter flexor digitorum profundus, I shall enter flexor digitorum profundus and not superficialis. If I want to go to pronator quadratus, I will look under ultrasound and go for pronator quadratus. If I wish to go in the shoulder, I know the sonoanatomy like this, and I have to know it, and all the people who work with me also know the sonoanatomy like this. So it's a very exact science. It is not shooting in the dark. Yeah? Yeah.
Thank you. Thank you, Doctor.
Atrophied muscle, if you are placing, how it works, mechanism of action.
Yes, very good. I'm very happy that you asked me this question. I could not cover it. So one of the questions that the reviewers asked was, what is this, that how does an atrophic muscle work? How does this, your co-contraction theory, how does it hold in hypertrophic phase, the dystrophic phase, and the atrophic phase? In the hypertrophic phase, it's a very angry muscle, and it is producing tenosynovitis in the hand. But then a very angry muscle continuously contracting puts a tremendous load on the resources, on the oxygen available, on the nutrients available. So they go for fibrosis and then ankylosis. That's why the hypertrophic to dystrophic to atrophic. And how does the needling affect this? Why should a fibrotic muscle regenerate after needling? Is because when I relax the muscle, when I say the muscle is dystrophic or atrophic, the muscle is not dead. It is just that it is working at maybe 10% of its capacity, and the fibrous skeleton of the muscle, all the facial layers get together to give you the hypertrophic appearance. So when you needle and you relax this muscle, the demand on the oxygen and the available nutrients comes down. It's a calming muscle. As a result, the muscle has a regenerative power and it comes back.
Madam,
Ma'am, when
does
you
it have any role in dupuytrentic contracture?
Pardon?
Does it have any role in
Yes.
dupuytrentic
Yes.
contracture?
Yes. I have recently published a paper on writer's cramp. It is online in pain medicine just now. Writer's cramp and so many conditions.
Yeah, so thank you very much all the speakers. We close this session here due to brevity of time. Thank you so much.
We'll be starting with a panel discussion. Hello. I'll use this. No, I want both. I want this also, and there has to be two mics there. I'll just invite our panelists for today, Dr. P.N. Jain, sir. He does not need any further introduction. He has been सारी conference पे छा गए हैं. Since yesterday, he has been attending so many sessions, and we are making full use of his presence here. Dr. Mayank Chansoria, one of the most dynamic young pain physicians from Jabalpur. He is also assistant professor and in charge of pain clinic at NSCB Medical College in Jabalpur. We have Dr. Mrs. Sanjot Ninave, who is in charge and coordinator of pain fellowship at DMMS deemed university. She is from Savangi Sevagram Vardha Medical College. And we have Dr. Vivek Chakole, who has done his FIPP from Budapest in 2013. And he is in charge of the pain clinic at CM Medical College, Durg, Chhattisgarh. I welcome all the panelists. And I think we'll start with our session. The topic given to us by Dr. Gautam Das was managing pain in difficult situations. I just thought of many case scenarios I discussed with my panelists, and we came up with certain cases which these people are finding very difficult in their own pain practice, and so we thought we'll start with it. However, some people approached me and told me that right now, so many people are being affected by one painful condition, and for that, do we have any answer for it? I mean, people have got a lot of frustration, pain, headaches, loss of sleep over this. So let me see if anybody can answer this. Panelists, any answers? No?
Waiting for the next station, for the next year.
Fair enough, our panel cannot answer this question. Okay, so let's get on with it. All right, so let's start up. This is case number 1, where a 52-year-old male patient was diagnosed with malignant intramedullary tumor of lumbar spine. He was referred to the pain clinic after severe shooting, burning pain radiating to both lower limbs, tingling numbness, feeling of heaviness in the legs, and could not sleep, had no appetite, loss of weight. No significant other any past history. He was presently put on tablet morphine 20 milligrams QID, tablet diclofenac 50 milligram TDS, along with pantoprazole, bisacordials, and the work. On examination, he was wheelchair and bedbound, catheterized, assisted movements. VAS was 9 or 10 on a score of NRS of 10, and loss of control over bowel bladder. Extremely depressed, power grade 2 to 3 in bilateral lower limbs. Hypoesthesia was present. Here, as you can see, the MRI is showing extensive recurrence of the tumor, collapse of L4 vertebra. So I request Dr. Jain to give his
So
opinion,
this
what
patient
more can be
obviously,
done.
this patient obviously has got nociceptive as well as neuropathic pain. So it's a mixed pain situation. Generally cancers have mixed pain where the tissues are also destroyed and the nerves are also entrapped. And in this patient already patient is having I think paraparesis. Grade is 2 to 3. So patient is not moving the limbs. And what about bladder and bowel dysfunction?
Already gone, sir.
So that is also gone. So it's a case where intramedullary tumor is there, and this patient has got burning and shooting pain. So that is also there. But this patient is receiving only morphine, diclofenac, and paracetamol. I did not see any antidepressants or anticonvulsants into that. So first issue that whether any radiation can be given to this patient, because we
It
have
was
to have a
given, sir.
comprehensive
It
care.
was done.
Radiation was.
Post-radiation, chemo, everything was over. sir.
So, cancer therapy is possibly out of purview, and already everything is tried. So this patient is having more or less end of life care situation,
True.
and we have to control pain. So as I said yesterday, the morphine comes into picture when there is severity of pain. So morphine has to be there, and whether escalating further, it increases the analgesia or increases side effects that you have to see in the patient. Whether patient is responding and patient is getting the pain relief, go on escalating. If the patient is getting sedated or feeling nauseated and not tolerating morphine, and patient is so, our experience says that morphine many times is refractory in such conditions. If you escalate morphine, you don't get much relief. So usually we give higher doses of antidepressant, anticonvulsant that will take care of burning and shooting pain. Then steroid therapy is very good option here. So for this actually high dose steroid therapy has been proposed and recommended. So there is a low dose steroid therapy, there is a high dose steroid therapy. You can go for methylprednisolone 30 milligram per kg body weight as a loading dose, and then you have to go for 4 milligram per kg body weight like it is given for status asthmaticus patient and other emergency conditions. So this is like a severe epidural cord compression situation, and where you have to give high dose steroid therapy. That will give very excellent pain relief by reducing the tumor mass, and edema, peritumoral edema can be reduced by steroids. So steroid here is very good option because steroid was not tried as I have seen here.
Yes.
So that is my management for this case.
Would any of the panelists like to add something to it?
Well said, sir. Thank you for organizing committee for calling us here as a panelist. For this case, as sir said, it is well said we can add morphine and increase the dose of morphine. We can add anticonvulsant. But here I can think that there is one source is tumor, and patient is already operated for surgery, and other source of pain may be the because already cord compression is there, sensory loss is there, and motor loss is there, also there. So the source of pain may be also the like Fehlback surgery syndrome, like from the that facet or this pain generator also can be thought. And
Certainly.
it can be as patient bladder boil has already been gone, we can think for the interventions also
Certain.
like that.
Which interventions?
Madam, thank you, the organizing committee, for giving me opportunity. Ma'am, I'd like to ask, sir, personally, I'm not having any exposure to intrathecal drug delivery system, but whether it can be tried in this patient, I want to know, anyone who is doing it, because it's an excellent option. What articles are coming up in these type of patients, but with this much severity of malignancy, whether we can do something with that intervention or not.
Actually,
When there is
That's-
obstruction, complete obstruction here, your drug will not go down. So many of the patient will not benefit. That is my experience is.
sir, but in this case, we actually did go ahead with, because the morphine, I had put it initially as 80 milligram per day, but then we increased the morphine to 150 milligrams per day. And like you rightly said, just increasing the morphine was having more of side effects than the effect itself. And finally, we took a spinal trial with morphine, and then we implanted the morphine pump in this patient. And the patient was there for almost 4 months. It's a pity, actually, we should have thought of this option much before. He would have enjoyed a more pain-free life. But then morphine pump was put in, and that brought the dose of morphine to almost 4 to 5 milligrams per day from his 150 milligrams, and it really took care of the side effects to a large extent. And this patient really, I mean, he was miserable. The motor power could not be helped, but at least the sensation of pain was under control and the side effects were controlled to a large degree. So the patient, like they rightly say, that he died a happy man.
But issue is where to put the catheter and where.
Sir, it has
where
to be above the
keep
level of
ca-
L4.
Tip of the catheter should be where should be the tip of
So
the
it was
catheter.
almost thoracic. We put it at, as you can see from this picture, sorry, you can't see the tip out here, but the catheter tip was much higher because the L4 was already collapsed. So your tip has to be much higher. So above L1, you have to put it.
But if you have no, if it is
Sir,
spinal
if you put it
obstruction,
over there, yeah, but it is at the level of L4, sir. So the cord ends at L1. So you put it intraspinally, intrathecally, above that level, and in this patient we had good pain control.
right?
I have
Moving
one
on.
concept, madam. Oh,
Yeah, and he had flexion deformity, like you could not put this patient flat also, even for refilling. So pretty bad condition
We can
actually,
take the
and we
tip
did the
above
refilling.
the obstructing part. We can
Yes,
take,
yes,
that is
it
the-
has to go.
That is the
I have one concept for this patient. We can take this patient as a terminally ill patient.
Yes,
You have patient is well-to-do, he can afford the intrathecal pump. If a patient is not affording intrathecal pump, we can give neurolytic block, intrathecal neurolytic block. Already bladder and bowel has been gone. Already muscle weakness and loss of sensation is there. So we can
I think Dr. Jain will be able to.
If the spinal obstruction is there, where your drug will go? It will
Sir,
not go there.
we can give at the L1 level. L1
Sir,
level
but the cord ends at L1, so if you are giving at that particular point, and will it help? I don't know.
L4, L5 level is also clear.
Intraspinal
Sir.
can we give?
You can give, but
Actually, I remember Dr. Gedu telling us about this before. He had given intrathecal. Is he there in the audience today?
you can give, but
I think
The
Dr. Kritika
effects-
presented.
the effects
you had
will not be
published a paper on
satisfactory.
this. Yeah.
The patient has pain in both lower limbs. So intrathecal would not be a good choice because intrathecal will cause deafferentation pain afterwards. And saddle block is what you can do. Now lower limb meaning you have to block from L.
but drug will not go down, no?
Yes, sir.
In saddle block also, drug will not go
Yes,
down. There is
so
obstruction.
Intrathecal is not the
The
choice,
choice.
at this level.
That's not the choice, yeah.
If it's a route, one route we can do. Bilateral, then epidural
For
neurolysis
that,
can
you
be
have to
done.
demonstrate the CSF down first. Whether there is a little races inside, and where you can demonstrate the CSF. So if CSF is there at L45, then of course you can go down. Otherwise, you can worsen the situation, whatever muscle power 2-3 is there. If patient develops paraplegia after your procedure, patient will be
Yes.
so much depressed that you have done a complication and you will be very difficult to save yourself. So do not do any procedure where you can worsen the patient muscle power in any case.
So the take-home message for, sorry madam. Madam, actually at this stage in his life, it did not make any sense to further investigate, like because the muscle power was not there, he was in severe pain, and increasing, like sir rightly said, increasing the morphine was the first thing that was tried, but he started getting lot of nausea, vomiting, somnolence, and psychological things. So this option for this particular case, but this is just a representative case of this group of cases. So I would like to know what the take-home message should be for the people
Ma'am,
in such scenarios. So like Dr. Jain has said,
what sir
titration
has
of morphine.
told us and what we have discussed, IDSS, our intrathecal drug release system definitely help, and corticosteroids definitely have a very big role in malignant spinal tumors, pain conditions. So these two are must, and if our morphine tablets are not working, they're having undue side effects, we can definitely go, if available, this better option.
So may I ask one
And
question?
also adding this gabapentin or pregabalin and also duloxetine type.
Absolutely.
But simultaneously, sir, interventional procedure accordingly without like less costlier affair, can we try with radio frequency ablation of DRG from 3, 4, 5, 6, whatever you want? Is it possible?
I'm
Because
not aware
the
about
doctor
any.
has said regarding intrathecal, which is costlier affair, and nobody like.
But it will not,
Non-upload.
I don't think it will take away the neuropathic pain. Because whole cord is
So you
under,
can add on
under
with
pressure.
DRG with sympathetic,
No,
sir.
I don't think RF has no role in this case, sir.
No. Like besides intrathecal, what are the other options which you can
Yeah,
prefer?
I got that, but for this particular case, because where will you do the RF?
DRG is not the option.
Is it
Yeah.
justified doing so many DRGs at the same time?
Yes. First,
Sir,
first
No,
thing
but it
that
will not help in this patient. Please,
sir,
sir.
can we give,
may,
can we do a epidural for a short time for unaffording patients at a higher level with local anesthetic and
but it
morphine?
will also take away the partial pain relief.
No, that
Yeah.
is for a week, maybe for 7 to 10 days,
Yes.
while steroids and neuropathic medications take over.
Certainly. So option,
Break in the pain.
here the discussion is that she chose intrathecal pump, but how many intrathecal pumps, who will give
Right.
4 lakh rupees,
Yes.
who has a training for intrathecal pump, that is the main discussion. What is the alternatives here?
Yes.
So alternative, I think systemic opioids or systemic analgesics, antidepressant, anticonvulsants, the major thing. That why that you can take away 60 to 70% pain relief. We cannot by anything relieve 100% pain relief. There cannot be 100% pain relief. So if you give life, quality of life little better,
Yes, sir.
so daily there is not a great suffering. That's it. That is the purpose of end of life care.
So one message I would like to give here is that morphine has got no ceiling dose, because lot of people have got inhibition about increasing the morphine more than 100 milligrams or something. I don't know why they have
No,
this
that is
idea.
not a
but
problem.
That
is not a problem. You can go up to
So,
any limit.
Yeah,
There are, yeah, there is no problem there.
Can I add something, please?
sure. Who is
I'm Dr. Malvinder from Delhi. If the patient has dermatomal distribution, there is a lot of emerging role of pulsed RF of the peripheral nerves. If we can identify the peripheral nerve, which is the dermatome causing pain, you can,
But
by
here
ultrasound,
it is, but here it is a central lesion, no?
yeah, central
lesion.
Central region, if you have, then the other option is, in our case where we have cancer patients, we can also admit them in ICU, give them low dose lignocaine plus ketamine infusion over weeks.
And that
treat
is
them.
that is fine.
That
Low dose
gives the
IV
patient
ketamine and
become totally
lignocaine is good.
energized. Yes.
If this patient comes with severe pain in the casualty, certainly if you give IV ketamine, IV lignocaine, it will give you very good pain relief. That is
No one
very good
mentioned-
idea.
yeah,
huh?
no one mentioned it, just
We
for
have got
mention.
one more
Good
case for
suggestion.
neuropathic, sir.
Yes.
That's excellent. Yes, it will definitely
Acute pain
help in
settings, yeah.
neuropathic.
Acute on chronic, yes.
Okay, second case most of us come across is chronic pancreatitis, because in CA pancreas the treatment is at different right from the outset. However, here the 35-year-old male patient came with it was alcohol-induced pancreatitis, complained of deep boring epigastric pain radiating to the back, increased with fatty food intake. Nausea and vomiting he was getting occasionally. There was loss of appetite, loss of weight, inadequate pain relief with pancreatic enzyme supplements, NSAIDs, PPI. Tramadol, paracetamol was giving, but he could not tolerate oral tramadol. He used to get a lot of nausea, vomiting with it. What all can we offer? I mean, I would like you to treat these cases as representing that group also, because we had to create a case here, so we are taking actual cases. But like say in chronic pancreatitis, what should be the protocol for pain management?
For this chronic pancreatitis pain, patient is alcoholic and already dehydrated. So the pain comes from the pancreas and peripancreatic region. So the pancreatic juice is very rich in bicarbonate and calcium. So there is always pancreatic calcifications are there, and the pancreatic duct goes under the spasm, and patient has a pain, or pancreatic duct will be obstructed, and patient will have pain whenever he will have food. So for this type of pain, of course we can do surgical interventions like freeze procedure like that, and other than that we can start the analgesics with disease modifying drug, like we can say like pregabalin, gabapentin, we can start. But if you are well to do, we can give splanchnic plexus, diagnostic splanchnic plexus block followed by RF splanchnic plexus.
Okay. That sounds like a very good suggestion, because for visceral pain, I'm sure any of the sympathetic blocks should definitely work. Sir, do you have any comment upon that?
Only word of caution is that we should not use alcohol for neurolysis here in these chronic pancreatitis patients. And even if you give a block with local anesthetic bupivacaine, the pain relief usually, in my experience, goes for 20 to 30 days with single shot of local anesthetic also when we are breaking the Bayesian cycle. And these patients will require certainly low dose of opioids also all the time. And you have to go on them. Then sometimes, after some time, the disease modifies itself. Disease goes into remission. Patient pain goes down. Then they do not require analgesic. Then again, after 2-3 months, something happens. Again, so this goes on and on. And I had one patient in Kolkata only with chronic pancreatitis, and he used to go internationally everywhere to sell some handicrafts, and used to come for celiac plexus block in my hospital, and 2-3 celiac plexus block with local anesthetic we have given here. So such patients go on. We have to counsel them, and they have to control their life and quality of life. So that is also very important.
You're right, sir. We tried celiac plexus block in this patient, but didn't yield any long-term effect. I mean, for some time they are pain-free, but that's about it.
I fully agree with sir, and I have tried splanchnic plexus, and I think it gives not excellent result, but a good amount of pain relief to these patients.
I don't have much experience with RF splanchnic, so is it working for a longer time? Not in this patient maybe, but overall for visceral pain, you have got good result?
Again, but neurolysis is a word of caution is there. Yeah, if patient develops some other pathology later on, then you already neuralize the visceral pathways. If the patient develops gangrene due to some other condition, due to volvulus, or patient will not have any pain.
Sir, may I? Doctor, may I?
Yes.
Hello. I have limited experience, but definite experience with splanchnic radiofrequency ablation. It does give good effect, but again, chronic pancreatitis patients using RF or neurolysis, I do not feel is correct. I mean, periodic pain, periodic treatment. That should be the way of life.
Can you give mic to the
I have a paper on this in the Journal of Palliative Care, which is going to come now. It is in print. So those who are interested in chronic pancreatic cancer pain, I have followed up celiac block as well as RF, splanchnic RF, with dry dry needling of the back muscles. Again, ultrasound guided with, anyway, the results are there. And I have also given the reason of why dry needling should be done. Because all visceral pains are referred to the abdominal wall. And when they are referred to the abdominal wall, they cause constant spasm. Constant spasm causes myofascial trigger points, and myofascial trigger points are addressed best by dry needling, not by celiac plexus block. Celiac catches one part of it. That is why you have 30% relief.
Here we are
40%
discussing
relief.
chronic pancreatitis. So this is here we are discussing chronic pancreatitis.
Okay, same story.
Yeah.
Anyway,
Yeah.
there in fact it is more indicated not to do a alcohol block.
Yes, yes.
Yeah, so the message so far has been that we can try, basically it's a very severe incapacitating pain, so we have to give some kind of pain relief. Would you like to give, apart from tramadol, would you like to give stronger analgesics like morphine to this patient?
Yes, sometimes
Chronic
they,
pancreatitis.
sometimes they come into severe pain and you have to use opioids. But counseling is again required. So if the patient goes into remission and he continues morphine, then he will go into addiction. So
Sir,
family
so-
should be counseled, patient should be counseled, then he should remain under your care continuously. So under physician care, addiction is not a problem. Problem occurs when the patient goes on his own and you are losing the follow-up and patient continues morphine from somewhere. So those type of
So can we
situation.
say, sir, the take-home message should be that morphine is related to the pain intensity and not life expectancy?
Yes, of course, these patients are going to live anyway.
Okay, in this patient, actually, finally the patient was affording, like Dr. Sakore keeps reminding me, and we considered the option of doing spinal cord stimulation in this patient. It was there are very few references for this, but not for chronic pancreatitis, but for visceral pain blocks, IBS and all, there are references where spinal cord stimulation was tried. In this patient also, we had this spinal cord stimulator IPG implanted. Patient responded very well to it. He came off Fortwin, to which he had become addicted during the course of his treatment. So yeah, spinal cord stimulation for non-specific visceral neuropathic pain also helps in some of these situations. Coming to the recommendation, by various bodies have given recommendations for management of chronic pancreatitis. In that, paracetamol wins the case because paracetamol should be used as the first line of treatment. NSAIDs off and on can be given for a short duration of time for acute and chronic type of pain. The recommendation is 1B. As a second step, tramadol can be recommended. And however, there seem to be many societies have come up with their own protocols, so the gradation keeps differing. But yes, tramadol seems to be another drug everybody seems to be attending to. Antioxidants have been shown to have long-term mild pain reduction. The level of evidence is 1B, and effectiveness of treatment with pancreatic enzymes has not been conclusively proven. However, there is a level of evidence of 1A from various other bodies. Coming to case 3, the patient has been referred. Yeah.
I would like to know what is the evidence of using spinal cord stimulator in chronic pancreatitis patient. If any of you can please enlighten the crowd. Spinal cord stimulator in a chronic pancreatitis patient. please.
There is no level 1 or level 2
There is no evidence right now.
There are
level
very
1 or
few
level
case
2.
reports.
There are no randomized trials.
No.
So I think
There are case reports only.
when such a
Case
panel
reports only.
discussion
There
is
is no
going on
documented
and
evidence.
a crowd is here where there is a mix and match, there are few absolutely new entrants, they will take a message that, well, this is a big gun, shoot it and patient is fine.
No, no, no.
So
Absolutely
please,
not.
please
I
convey
said
that
that.
this is
No, no,
not
no,
that
no.
line of treatment.
Yes.
Probably they got a result, that is luck.
There is also a case report.
Absolutely.
Yeah.
That's what I mentioned in the recommendations. There is absolutely no recommendation. So evidence does not back this at all. In
She
chronic
told about
pancreatitis.
that, doctor.
I said that.
She told that there is no recommendation.
Yeah, this is what was tried and patient got relief, but no, absolutely, you are absolutely on dot. There is no recommendation like I mentioned in my table of recommendations. In case 3, this patient was referred from medicine department to the pain clinic. Patient known case of HIV on ARV. complaints of burning pain in both feet since 4 months, chronic intolerance to medications, history of nausea, vomiting, GI complaints, edema over both lower limbs, and no other comorbid illnesses. CD4 cell count was 180 cells, history of alcohol intake, probable diagnosis of DSP was made. DSP in this case is distal symmetric polyneuropathy. I would like to ask Dr. Mayank Chansoria because he has managed this case.
Thank you, ma'am. I'd like to discuss this case because it's one of the most difficult cases which I faced, and it really gave me a lot of shivers. And I want you in front of so many seniors that we discuss it, and so that we come up a more good approach to these kind of patients. Actually, this type of patient was referred to me in my pain clinic with all these features. He was having distal symmetric polyneuropathy, and the main complaint was that he's having severe burning pain in both the feet, to the extent that that patient was not sleeping in nights and continuously rubbing cold ice and cold water to his feet. And apart from that, the relatives gave a very prominent complaint that don't give any strong medications to my patient. He's not tolerating any medications. So please be careful while prescribing medications. So apart from the history, it was evident that as peripheral, the most common neurological complication in HIV patients is peripheral neuropathy. So it was the first probable diagnosis which came to my mind. And from the relatives' perspective, I started this patient on low-dose simple paracetamol and gabapentin. After 8 to 10 days, that patient again came to me and told me that your medications are not working. The patient is not having any pain relief. Apart from that, he's having severe nausea, severe vomiting, GI complaints are not ending up, and frequent pedal edemas are coming up. And so we told you earlier, please stop these medications. So I told him, okay, we'll try to change it. And I reduced the dose of paracetamol and added a bit of tramadol and changed from gabapentin to nortriptyline. And that too, half dose in the night. Again, after a week or so, the relatives called me up and told me, sir, we have told you not to prescribe strong medications. The patient is not well at all. He's drowsy. His constipation is so severe that we are getting him admitted. And we told you and you didn't listen to us. And we'll be going to the superintendent. So ultimately, this patient, I discussed this case with one of my neurophysician friend and asked him, you just have a look at this patient and see something I'm missing or not. So he examined, get a nerve conduction tests, which are all.
Can we stick to
Okay.
representative rather than.
So ultimately, after getting involvement of so many faculties, it was evident that the autonomic component was a very major factor in this patient, apart from the peripheral neuropathy, and all these complaints were due to autonomic component, and ultimately autonomic neuropathy as frequently seen in diabetic patients, which I was missing up because I was having no idea that I should go in for this. And ultimately, apart from the basic medical management, a symptom-specific management was started in discussion with the other faculties that the patient should be told to take a lot of fluids.
Ablation of DRG from 3, 4, 5, 6, whatever you want. Is it possible?
I'm
Because
not aware
the
about
doctor
any.
has said regarding intrathecal, which is costly affair, and nobody like.
But it will not,
Non-upload.
I don't think it will take away the neuropathic pain. Because whole cord is
So you
under,
can add on
under
with
pressure.
DRG with sympathetic,
No,
sir.
I don't think RF has no role in this case, sir.
No. Like besides intrathecal, what are the other options which you can
Yeah,
prefer?
I got that, but for this particular case, because where will you do the RF?
DRG is not the option.
Is it
Yeah.
justified doing so many DRGs at the same time?
Yes. First,
So,
first
No,
thing
but it
that
will not help in this patient. Please,
so
sir.
can we give,
may,
can we do a epidural for a short time for unaffording patients at a higher level with local anesthetic and
but it
morphine?
will also take away the partial pain relief.
No, that
Yeah.
is for a week, maybe for 7 to 10 days, while steroids and neuropathic medications take over.
Certainly. So option,
Break in the pain.
here the discussion is that she chose intrathecal pump, but how many intrathecal pumps, who will give
Right.
4 lakh rupees,
Yes.
who has a training for intrathecal pump, that is the main discussion. What is the alternatives here?
Yes.
So alternative, I think systemic opioids or systemic analgesics, antidepressant, anticonvulsants, the major thing. That why that you can take away 60 to 70% pain relief. We cannot buy anything relieve 100% pain relief. There cannot be 100% pain relief. So if you give life, quality of life little better,
Yes, sir.
so daily there is not a great suffering. That's it. That is the purpose of end of life care.
So one message I would like to give here is that morphine has got no ceiling dose, because lot of people have got inhibition about increasing the morphine more than 100 milligrams or something. I don't know why they have
No,
this
that
idea.
is not a
but
problem.
That
That is not a problem. You can go up to
So,
any limit.
Yeah,
There are, yeah, there is no problem there.
Can I add something, please?
sure. Who is
I'm Dr. Malvinder from Delhi. If the patient has dermatomal distribution, there is a lot of emerging role of pulsed RF of the peripheral nerves. If we can identify the peripheral nerve, which is the dermatome causing pain, you can
But
by
here
ultrasound.
it is, but here it is a central lesion, no?
Yeah, central
lesion.
Central region, if you have, then the other option is, in our case where we have cancer patients, you can also admit them in ICU, give them low dose lignocaine plus ketamine infusion over weeks.
And that is, that is fine.
That
Low dose
gives the
IV
patient
ketamine and
become totally
lignocaine is good.
analgesic. Yes.
If this patient comes with severe pain in the casualty, certainly if you give IV ketamine, IV lignocaine, it will give you very good pain relief. That is
No one
very good
mentioned-
idea.
yeah,
huh?
no one mentioned it, just
We
for
have got
mention.
one more
Good
case for
suggestion.
neuropathic, sir.
Yes.
That's excellent. Yes, it will definitely
Acute pain
help in
settings, yeah.
neuropathic.
Acute on chronic, yes.
Okay, second case most of us come across is chronic pancreatitis, because in CA pancreas the treatment is at different right from the outset. However, here the 35-year-old male patient came with, it was alcohol-induced pancreatitis, complained of deep boring epigastric pain radiating to the back, increased with fatty food intake, nausea and vomiting he was getting occasionally. There was loss of appetite, loss of weight, inadequate pain relief with pancreatic enzyme supplements, NSAIDs, PPI. Tramadol, paracetamol was giving, but he could not tolerate oral tramadol. He used to get a lot of nausea, vomiting with it. What all can we offer? I mean, I would like you to treat these cases as representing that group also, because we had to create a case here, so we are taking actual cases. But like say in chronic pancreatitis, what should be the protocol for pain management?
For this chronic pancreatitis pain, patient is alcoholic and already dehydrated. So the pain comes from the pancreas and peripancreatic region. So the pancreatic juice is very rich in bicarbonate and calcium. So there is always pancreatic calcifications are there, and the pancreatic duct goes under the spasm, and patient has a pain, or pancreatic duct will be obstructed, and patient will have pain whenever he will have food. So for this type of pain, of course we can do surgical interventions like freeze procedure like that, and other than that we can start the analgesics with disease modifying drug, like we can say like pregabalin, gabapentin, we can start. But if you are well to do, we can give splanchnic plexus, diagnostic splanchnic plexus block followed by RF splanchnic plexus.
Okay. That sounds like a very good suggestion, because for visceral pain, I'm sure any of the sympathetic blocks should definitely work. Sir, do you have any comment upon that?
Only word of caution is that we should not use alcohol for neurolysis here in these chronic pancreatitis patients. And even if you give a block with local anesthetic, bupivacaine, the pain relief usually in my experience goes for 20 to 30 days with single shot of local anesthetic also when we are breaking the Basia cycle. And these patients will require certainly low dose of opioids also all the time. And you have to go on them, then sometimes after some time the disease modifies itself, disease goes into remission, patient pain goes down, then they do not require analgesic. Then again after 2-3 months something happens. Again, so this goes on and on. And I had one patient in Kolkata only with chronic pancreatitis, and he used to go internationally everywhere to sell some handicrafts, and used to come for celiac plexus block in my hospital, and 2-3 celiac plexus block with local anesthetic we have given here. So such patients go on. We have to counsel them, and they have to control their life and quality of life. So that is also very important.
You're right, sir. We tried celiac plexus block in this patient, but didn't yield any long-term effect. I mean, for some time they are pain-free, but that's about it.
I fully agree with sir, and I have tried splanchnic plexus, and I think it gives not excellent result, but a good amount of pain relief to these patients.
I don't have much experience with RF splanchnic, so is it working for a longer time? Not in this patient maybe, but overall for visceral pain, you have got good result?
Again, but neurolysis is a word of caution is there. Yeah, if patient develops some other pathology later on, then you already neuralize the visceral pathways. If the patient develops gangrene due to some other condition, due to volvulus, or patient will not have any pain.
Sir, may I? Doctor, may I?
Yes.
Hello. I have limited experience, but definite experience with splanchnic radiofrequency ablation. It does give good effect, but again, chronic pancreatitis patients using RF or neurolysis, I do not feel is correct. I mean, periodic pain, periodic treatment, that should be the way of life.
Can you give mic to the
I have a paper on this in the Journal of Palliative Care, which is going to come now. It is in print. So those who are interested in chronic pancreatic cancer pain, I have followed up celiac block as well as RF, splanchnic RF, with dry needling of the back muscles. Again, ultrasound guided. With anyway, the results are there, and I have also given the reason of why dry needling should be done, because all visceral pains are referred to the abdominal wall, and when they are referred to the abdominal wall, they cause constant spasm. Constant spasm causes myofascial trigger points, and myofascial trigger points are addressed best by dry needling, not by celiac plexus block. Celiac catches one part of it. That is why you have 30% relief.
Here we are
40%
discussing
relief.
chronic pancreatitis.
No.
So this is here we are